Hello everyone, and thank you for joining us for the October Educational Webinar. Today we are happy to welcome back Dr. Carolyn Ellis for her presentation, The Long Goodbye, Grief and Caregiver Stress in End-of-Life Care.
Hello everyone, this is Dr. Carolyn Ellis, and thank you so much for being with me today to talk about a topic that is very near and dear to my heart. I have been working in end-of-life care now for 4 years, and I've been working with the VA and in palliative care, hospice, oncology, and also in primary care, and I have noticed the impact of grief and, kind of that experience of the long goodbye on our caregivers, and I think it can be very different from our traditional understanding of grief, and also our options and our ability to support people can be very different in this particular role. So I'm really excited to kind of have a chance to talk to you all about this. And I'm sure you are all partial experts to begin with, working as CSAs. So a lot of this material will be in a realm of familiarity with you. And then I'm going to give you some additional background too. But what I'd like to start with today is a Buddhist parable, and this is actually one of my favorite parables, especially in use in therapy. And this is a very ancient Buddhist story, and it starts with a woman who lost her only son, and this caused her great pain, and she took his body and she held on to it. And the villagers came to her and said, we want to bury your son. And she said, no, there must be a way to bring him back to life. There must be a way to fix this. And so she went around to villager after villager, and finally someone said to her, go to the Buddha and talk to the Buddha. Maybe there's something that he can make. Maybe there's something he can do for you. So she goes to the Buddha, and he says, oh, yes, there is a potion that can bring your son back to life, but what I will need from you is a mustard seed, and you must obtain this mustard seed from a home that has never been touched by death. So the woman goes out into the village and goes door to door asking people, I need a mustard seed. Has your home been touched by death? And they said, oh, I'm so sorry. I've lost a husband, mother, father. As she goes around the village, each person is very compassionate and kind to her, but she soon realizes that there's not a single home that has not been touched by death. And so at this point, she hands over her son to the villagers who want to help her to go through with the burial practices. And she returns to the Buddha and says, thank you for showing me the reality that everyone experiences the pain of death. And he said to her, and he said, yes, this is true. And knowing this does not take away your grief, but it eases some of the suffering of holding on. And that's kind of, what I love about this parable is, first of all, it's ancient, but it is also relevant because there's not a single one of us that has been untouched by death. And there's not a single one of us that has not in some way, shape, or form grieved ourselves or helped someone else grieve. And I think this village concept is very important because truly every person that you will ever interact with will experience grief in some way. So in this webinar today, what I'm going to talk about is what is grief, some of the theories of grief, and then grief and caregiving, its impact, aspects of culture, and also the process, and most importantly, because I know that you are compassionate people who seek out being a CSA because of your desire to help seniors and their families. So we really want to focus on ways that you can help, and you don't need to be a psychologist in order to help someone with grief and truly be a beneficial and meaningful person in the lives of your clients who are experiencing issues. So I'm going to open a little bit with definitions because I think we use a lot of terms when we're talking about grief interchangeably, and there are some important distinctions that are made in kind of scientific study. But what's good to know is that there is grief, which is defined by this deep sorrow, so especially that caused by someone's death. Right? And then there's mourning, which is the period of time that we grieve. And then there's bereavement, and I've always loved this word because the word bereavement actually means to be bereaved. It means to have something taken away from you. So the state of bereavement actually means that you have been deprived of something, and I think that's very valuable because the concept of loss is really prevalent in grief, and it's particularly important to the things that we're going to talk about today. Now, many people are familiar with Elizabeth Kubler-Ross's stages of grief, and we are going to get there, but who I wanted to actually talk about first is Bowlby. And Bowlby is a British psychiatrist who actually is the father of modern attachment theory and the understanding of children and attachment. And he actually is the first person who really attempted to look at grief, and Kubler-Ross was significantly influenced by his studies. And these are very kind of familiar experiences for each of you, and he actually, believe it or not, noticed these in children first before he noticed them in adults. And that first stage is that shock and numbness. And this is the phase where there's a sense of loss, but it's not quite real. We haven't quite accepted it. What's going on? And at each of these stages, there's kind of a fundamental process that we need to go through in order to move forward with grief. And so some of these problems that we have with grieving can actually be what we call stuck points, getting stuck in a process. But this initial process of shock and numbness sometimes leads to emotionally shutting down and having difficulty really approaching grief. However, it is a natural part, and I think the thing that I really want to emphasize with grief is it is a natural process. Grieving exists, right? And so shock and numbness are okay, and it is okay to be in this stage. It is okay to take some time and experience that shock and that numbing and that questioning. And that's usually what transitions people into this yearning and searching phase. And this is the phase where we're now aware that there's a huge void in our life. You know, we understand that this person is no longer with us, right? And we yearn for the person. We have thoughts and memories, and we miss them so much. And we're searching for something to fill, alleviate some of that pain, right? And then we naturally transition into an experience of despair and disorganization. And I want to emphasize again that despair and disorganization are natural components of grief. It's okay to go there. It's okay to just feel down and awful and miss someone genuinely and to be a little confabulated. And how, you know, and we'll talk about this later in the webinar, but there are significant cognitive changes that actually come with the grieving process that have been documented in research. So we all feel a little disorganized, and rightly so. This is normal. And then hopefully we reach a point of reorganization and recovery where we start to kind of, you know, get ourselves back a little, you know, get back on track, you know, learn some of those roles and those ways of living, you know, without the person, and actually have a concept of recovery. So this work is what significantly influeed Kubler-Ross to go into her death and dying and grief research, and she found that basically all people go through these 5 stages. And originally she actually thought this was only approaching death. This was only for people who were, you know, given a terminal illness. And then later found that truly it absolutely applies to grief and loss. And that first stage, very similar to that shock and numbness, is denial. And anyone who's ever worked in a setting with police officers or any professionals who are you know, required to give bad news knows very well what this stage of denial is. Are you sure? No, this is not possible. That couldn't have happened. I was just talking to her yesterday, right? Denial is a very powerful thing, and this is what Freud would call a defense mechanism. And the defense mechanisms do just that. They defend us from harm, and denial is a very powerful one. But it's not something that can be permanent, right? Because eventually you do realize that the person is actually gone. And Kubler-Ross was the first person, and thank goodness for her for bringing this up, to note that anger is a big issue when it comes to grieving, and it's true, and anger is real, and people do feel angry. And once again, we want to emphasize the fact that anger is a normal experience in this case, that anger is an understandable result of being bereft, of being deprived, of having something you love taken away from you. And then often we get to a bargaining stage, right? And you know, there are spiritual components to this. People beg God, they'll beg friends, they'll beg others, they'll rant and rave and say, why are you gone, and come back, you know, things like that. And then what happens is when the bargaining doesn't result in what they're hoping for, people often lead into a depression. They feel sad, they feel lost. And this is a principal stage of recovery, is to actually go through this valley of just feeling the sadness and approaching this area of acceptance. And so acceptance is what they consider the final stage of grief. And we're definitely going to get into a little bit of that concept of finality coming up. Right now I just want to provide you with a little bit of foundation of kind of these theories and also the factors that come into play when people are grieving. So these 5 stages of grief, according to Kubler-Ross, have been expanded on in recent years, and they call this the modified model. And they've added that shock, because truly shock is a little different from denial. The initial paralysis, just that, kind of complete lack of cognitive awareness or what is going on around me, isn't quite denial. Like, shock is a true state. And so sometimes people haven't even, they're not necessarily in denial, they're just still in shock. And then there's also that testing, and I do like the testing phase being added prior to acceptance, because I think we don't just naturally transition from feeling sad to accepting things as they are. I think we actually do go through a phase of attempting acceptance and finding that that attempt didn't work, or attempting another form of moving forward and finding that that didn't work. So now that one of the kind of ongoing models is the 7 stages of grief, and that these are all prevalent. And the way that we find these in psychological studies is what we do is we have people talk about and report what their symptoms are and what their experiences are, and what we do is what we call factor analysis, where we kind of create common themes. Like if I say to you, a carrot and broccoli, you think, oh, they're vegetables, right? So we look at all of these different experiences that tend to go under one umbrella. So we have found in studies of thousands of people who are grieving that they tend to experience these broad categories. Another one is Horowitz, and I really like Horowitz, because Horowitz really focuses on the outcry. And I think a lot of grief, denial is not the same as outcry, although it's kind of a part of this stage. But I think mourning, originally was described, if you look at literature and historical information, you see weeping and gnashing of teeth, right? You see people physically doing things to express their mourning. And I think that outcry really grabs a hold of this. And Horowitz was influenced significantly by Bowlby and Kubler-Ross as well. And then from that, oh my goodness, why is this happening? What is going on? From that outcry, people transition to that denial and intrusion. And I like this. We both deny and recognize at the same time. This is a natural part of human existence. We say, oh, the person's not gone, and then we see a photo of them and we're heartbroken because deep down we know that they're gone. So what I love about this is it really balances that understanding that we both deny and have intrusion of memory at the same time. And then there's working through, which is a difficult, probably one of the most difficult aspects of grief, is how do you kind of scrape yourself up off the floor and move forward, right? And then completion. What I love about Horowitz is he was never the one to say, you're done and you're fixed. He's at some point in time, he says, months to years, the process of grieving is completed. And by completed, I mean it's completed enough. It means that you can return to some feeling that life is a little bit normal again. And I've always appreciated his kind of approach to that. And the last one that we're going to talk about, and I know that I'm giving you kind of a lot of psychological background, but there's a reason for this, and this provides the foundation for us as we progress through this particular webinar, and that's Worden's tasks of mourning. And he talks about that task 1, and grant you, have you been noticing all of these common themes? These, this accepting and denial and shock and things like that, because what we're finding is, once again, we've had many different researchers look at thousands of different people grieving, and over and over and over again, the human experience of grief is the same. And so that first task is accepting the reality of it, right? Is saying, there really is a loss, this person really is gone. And then the second task is that working through, right? That moving forward. And then you go on to adjusting to an environment in which the deceased is missing. So this is really interesting, is that, actually assuming different roles and changing the way you interact and what you do, and some of the tangible things that you need to do in order to move forward with that another person in your life. And then this is very interesting. Task number 4, to find an enduring connection with the deceased while embarking on a new life. This actually has been found to be very significant in research of parents who have lost children. And we found that parents who have lost children tend to cope the best when they can somehow establish some form of relationship with the deceased child and actually move forward and continue to grow with this person conceptually in their lives. And that has been shown to be a very healthy way of grieving and a very important task in loss. So as we look at all of these, what I want to examine with all of you, as we look at grief, we can all kind of say, oh, I recognize that. That makes sense. I've seen that before. I've felt that before. Oh, that explains why I got so angry. And I had no idea why I was so angry when I lost such and such. But these really do emphasize finality, okay? So most of our understanding of grief so far says that the person is gone, and we are now adjusting to life with the person being gone, and this person will never come back. And it's really emphasizing that finality, like we must make a smooth transition. It also suggests a linear relationship. And I think this is my greatest frustration with theories of grief, is that grief is not linear. We do not naturally go from shock to, in this case, like shock to anger. Sometimes people go shock to depression, and then 2 months later they're feeling angry, right? Whereas all of these stages exist, they may not exactly exist in that linear relationship that is strongly suggested by all of these theories. And kind of in the realm of emphasizing finality, like we said before, they only allow really for a fixed transition. Person was there, person's not. Roles before, roles after, right? And this, as we all know, does not work very well for our work with seniors and their families and our aging clients. We do not have fixed transitions. We have a lot of different types of processes. So the important thing to remember, though, for all of you is my great summary of the process of grief is I don't want you to think of it as a linear process. I want you to know that all of these stages do exist, but I want you to think of them like this. They are a roller coaster, and they loop back on each other, and you think you're done with the ride, and lo and behold, you're back at the beginning, and you're going through the same loops all over again. And that is how grief works. And once again, that is okay. It is not linear, and it is not smooth. But as long as you continue to move and process, the ride gets easier, and eventually the goal is that you do get to get off the roller coaster. However, one thing I always will say to people is, there's no such thing as pure acceptance. In this case, you accept and things come and hit you again, and that's okay. When you ask anybody who's lost someone, anniversaries are almost always hard, right? They may change from year to year, but it can be difficult. So there's going to be periods of time in your life where you get back on the roller coaster, but the goal of all grief process is the ride is shorter each and every time. So this is one of my absolute favorite quotes, and I really appreciate it because Ernest Dimnett talks about the happiness of most people is not ruined by great catastrophes or fatal errors, but by the repetition of slowly destructive little things. And I think that this really gets to the heart of grief in caregiving and grief in terminal illness or chronic illness or just the natural debilitating process of age. So what's missing from our current model of grief? We've talked about the nature of loss and the fact that most models are focusing on that permanent grief, that death. But there are progressive losses, and these are losses that are physical, social, and emotional. Right? So it's very interesting. Lascalzo, and I always get the other name wrong, Britzen Hofzuck, did a study on grief and found that losses begin with the onset of symptoms for caregivers. So decreased function, increased fatigue, and they continue as symptoms of progressive illness become more pronounced and intensify during the active dying process. So grief starts when the person that people are caring for gets sick. And it continues the entire time that they are alive with each and every additional loss, physical, social, or emotional. And this is very interesting because it's not necessarily identified as grief, and this is where you guys are going to come in and kind of be brilliant experts on the matter. So when we look at grief, grief has measurable, witnessed, reportable symptoms in every aspect of a human being's functioning. grief has biological side effects. So there was a qualitative analysis that was done by the field of social work years ago, and this was in 2007, and they found that the distinct physical health-related features of distress associated with caregiving and ongoing loss really occurred during end-stage care, and that was sleep disruption, exacerbation of chronic illness, and physical strain. They had physical problems with people, including nausea. And these are what we call idiopathic, right? These are not caregivers who necessarily had pre-existing issues, right? Changes in appetite, physical nausea, psychosomatic complaints. And so I always take issue with the word psychosomatic, because all illness is psychosomatic. All illness has psychological and physical components. Even if it's a fully physical disease, you best believe that chronic disease affects the emotions and the psyche, right? But psychosomatic complaints are generally defined as those for which there is a physical complaint with no known physical cause, and those are called idiopathic, no known cause. So a lot of these biological components of caregiving are witnessed in symptoms, physical symptoms, in the person who's providing caregiving. These are also witnessed in grief. Grief has biological symptoms, and there are some up and rising theories stating that the pressure of caregiving may not necessarily be, quote-unquote, the stress of caregiving, but it may actually be the normal grief process that is not getting attended to because people don't consider the act of caregiving ongoing grief. And that's where, you know, part of what we're talking about today. And then the social world, right? Grieving affects us socially, right? And now there are religious practices and things like, I believe it's called Shiva in the Jewish tradition, where you aid people in mourning. And there's a lot of different things that people do to kind of provide support during the grieving process, but it's always impactful socially because people don't know what to say. They don't know if they should or should not come over. You know, should or should I not bring food, right? So it has a significant impact on the people involved, right? And so caregivers, in addition to this, caregivers have the experience of loss of social network, right? And and oftentimes they don't have time to get out and be more social, but they also have changing roles, right? And then also, you know, that whole piece of denial and kind of changing roles in families can sometimes mean that caregivers who previously had the support of people don't have it anymore because they don't want to be around the person who is dying or ailed, and they just can't see it themselves. So the caregivers can sometimes get abandoned, right? And so moving on to that spiritual concept, right? So spiritual impact of both grief and caregiving is very, very similar. That questioning of why are things happening, right? And where is my comfort? And what are the concepts of death and dying that come into play? And are they seeking out community and pastoral care? And then the psychological components. And now, just to note, the reason why we show a Venn diagram is the spiritual lens into the social and the biological and the psychological, and all of these things interact with each other. And so it's important for us to remember that truly everything is constantly interacting. And psychological symptoms are very specific when it comes to caregiving and grief, and these features include sadness and anger. So isn't that interesting that when they did a study of caregiver experiences and they did a study of people going through grief at the loss of a loved one, the two groups both identified sadness and anger as their most significant and difficult things to deal with. And yet we still don't necessarily identify the burdens of caregiving with active grief process. One of the things that I really want to emphasize, though, is that biological component, because caregiving and grief especially, have been linked with mortality. So caregiving itself is not necessarily, it's not a predictor of mortality. In fact, actually, caregivers who donate about 14 hours of time per week to the care of another person have protective factors. There's actually kind of an altruistic, emotional, psychospiritual benefit that comes from that makes them less susceptible to disease and a lot of other things. And I want you guys all to know that this is very valuable in your particular profession because you are donating hours and time of your life in order to help people and help them see through some of these processes. So you are caregivers in a way, and do not discredit the act of caregiving or the donation of your time, energy, and care to people just because you're getting paid for it. You are absolutely caregivers who are valuable, contributing people to the lives of the clients that you work with. But what's interesting is when you look at the actual higher mortality rates, and especially in widowing, right? But so Schultz and Beach found that elderly spousal caregivers who experience caregiving-related stress have a 63% higher mortality rate than non-caregivers. And then we look at widowhood is associated with higher mortality in both sexes. Now, women tend to have more physical, those psychosomatic symptoms, but men have higher death rates. So the question is it caregiving or is it grief that is causing this mortality? Is the strain of caregiving the same as the strain of grief? Because we know that grief actually impacts mortality independently in and of itself in the instance of sudden death. And we're finding that caregiving impacts mortality. And there's that question of, are caregiving and grieving almost in some ways the same thing? So caregiving perceptions. So caregiving studies have emphasized both negative and positive feelings associated with caregiving, and these are important to note because you're going to have the experience of talking to people about their feelings and their perceptions and their experience of caregiving. Recent caregiving studies have emphasized that people really do kind of tend to lean more towards one side, but almost always experience both negative and positive emotions. So negative feelings are those like, I wish I had done more, or perceptions of mistakes, or regrets about unresolved issues, negative perceptions of caregiving. What's interesting is, once again, you go into that guilt, which is often related to these experiences and feelings of anger that caregivers have, and then they feel guilty about feeling angry and not understanding why they're angry. And of course, it's not the fault of the person that I'm caring about, but I don't understand why I'm so angry. And now at the back of your minds, I want you to all have kind of a little flag that rises up and says, wait a minute, anger is a natural stage of grief, right? Okay, wait, anger is a completely normal aspect of what you're going through, but people don't see it that way, and we don't either in our daily lives when we get angry at a loss. We just, kind of think, oh man, I shouldn't be getting angry. And then some of those positive experiences have also been identified, and people, even if they are really frustrated or really fatigued, will often identify with a sense of satisfaction or meaning making, or the idea that I was there at the final shared times as I did something. Often sense of reconciliation or making up for past mistakes or really contributing to the well-being of somebody that they loved, right? So there are often positive feelings that are associated as well. There are a lot of cultural considerations that come into play with this, and I really, it's a fascinating study actually of the impact of culture on grief, because it starts with that nature of the relationship between the caregiver and the receiver. Whether or not it's a close family member, whether or not it's a paid caregiver, and like I said, never underestimate the emotional impact of loss and progressive loss on paid caregivers too, because oftentimes people just have a genuine care and compassion for the people that they're working with, right? So whether or not there's a sense of familial obligation, right? Is this just what you do? Are you the long-suffering spouse? In our culture, what do we, is this just what we do? Or is there begrudging, I shouldn't have to take care of you, I'm supposed to be taking care of my kids and I'm taking care of you. So there are a lot of different cultural considerations that actually go into this experience of positive and negative emotion and caregiving. And that is often based on the nature of the relationship. Attitudes toward death. Now, if you're a person like me who's been working in this field long enough, you have kind of an interesting understanding of the history, and I find the information fascinating, and grant you, I think, after 4 years of family meetings and end-of-life decision-making discussions, you do start to kind of just realize that this is a fact of life, but obviously death is not exactly an easy topic for people. But attitudes toward death have really changed, actually, in the history of Western culture. So let's see, I don't know if it, quite Renaissance era. I think the Middle Ages, death was a very shameful thing, right? And it was evidence of, kind of a problem that you had with spirits or God, and it was really something that was hidden away. And then there was a transition, really, to where death was no longer shameful, and that death was okay, and that it was a part of life, where people actually started to institute ritual, right, where it wasn't just, someone died and they burned the bodies to prevent further disease, but they actually focused on funeral ritual, and they focused on mourning and things like that. So they kind of transitioned into this time of recognizing death and honoring death, and moving from that shameful place to that, death is a part of life, or death is even something to be celebrated in the life of the person who died. But what's interesting is if you look at the United States, we had a very unique cultural shift that doesn't necessarily go with a lot of other cultures, which is that idea that people no longer die at home, and that they go to hospice care facilities. And this is not to say that hospice care is a bad place. In fact, the term hospice actually, I think it comes from the same term where we get hostel, right? Is that the idea of a lovely place where people can stay, so the idea of, kind of a guest house, right? But attitudes toward death have actually transitioned, and people do still kind of exist in this continuum of death being a shameful, complicated thing to something to be honored, celebrated, something to be done at home, something to be done away from home. And these are important things to consider in the grief process, also in the experience of anger and guilt and sadness, and also to understand in your clients, what are their attitudes. This includes things like concepts of the afterlife, right? Death anxiety tends to be a lot, greater when people are worried about what's going to happen after, versus feeling very accepted and feeling very at peace with whatever their concept is of what's going to happen after. You hear this in terms of people saying, oh, he's going to be at peace, right? Or, I know where I'm going and it's a beautiful place and I'll get to see everyone again, right? And then also where the caregiving is taking place. So also, we talked a little bit about whether or not they're being taken care of at home or in a hospice, but also once again, who's home, who else is involved, things like that. So there are considerations that do come into the experience of caregivers that actually impact their experience. So what we have found is that caregivers tend to experience all of the stages of grief that we have discussed in an ongoing, recurrent process. And, going back to that roller coaster, you can imagine that that's a difficult ride to continue on. And then when we come to the end, there's actually two models of caregiver grief that we have discovered. And the first one is the relief model. And there are occasions where caregivers, at the time of the death of the person they've been caring for, who really say, now it is a resolution. It is a resolution of distress. The person is at peace. Things are okay. Now we can, I can reestablish some form of social life or leisure time or build back up those psychological resources and begin the process of moving forward. And this is not to lessen the experience of grief at all. It's not that people in the relief model don't miss the loved one, but there is somewhat of a peace and an acceptance that comes with it. And the second one is the complicated model, and it really is just as it sounds. I got to give, psychology a lot of credit because we really do love to call things exactly what they are. But the complicated model is just that. It portrays how distress can actually be exacerbated after death and heightened, right? So the heightened role strain from caregiving may lead to greater difficulty in bereavement because, they've had only kind of one understanding of themselves and they've been just plugging away and moving forward with caring for this other person, and now that that role isn't there anymore, now that that person isn't there, they don't know who they are, what they're supposed to do, and oftentimes in the complicated model, they feel unresolved issues. I should have, I wish I had, oh, if only we had, right? So kind of that hindsight bias that comes from, if only I had known then what I know now, I would have done a better job. So it's important to note that in addition to those traditional components of grief, those denial, the anger, the depression, the shock, caregiving grief comes with it kind of a gateway into further experience, which can either be manifested in relief or can be very complex and complicated and can be very difficult for people to adjust to. So anticipatory grief is an ongoing process. Kind of what I've been alluding to this whole time is the idea that caregiving in and of itself constitutes a series of grief processes, and that caregivers process the stages of grief at each loss. They grieve the loss of roles, memories, companionship. If you've ever listened to older people who are taking care of their loved ones, you'll hear the stories of, I remember when, right? And it's so hard to see him or her this way now. And she or he used to be the smartest person in the room or the most talented artist, things like that. And also the loneliness that comes from having spent so many years of your life with another person, you know, your best friend. And now that same person isn't necessarily there anymore. So this is ongoing grief, and caregiver grief is not that terminal, final, you know, great, it's happened, now we can move forward, one fixed transition of role. It is grief after grief and process after process, and you come to acceptance right at the stage where another loss occurs and you move forward again. So it is really an aspect of endurance and a huge kind of whole body, mind, psyche impact on the people with whom we work. So a lot of this may make sense, and a lot of this may, you know, resonate with all of you who are listening who work with caregivers and older persons and older clients, and you may say, oh, I've recognized that, I've seen it. You know, you're working in the field, you're frontline infantry who really understand this process from an up-close place. And that begs the question, what can we do? You know, thank you, Dr. Ellis, for telling us all of the stuff. You know, it makes sense, but you know, it feels overwhelming. It feels insurmountable. And how do you grab someone from a moving roller coaster and help them out? And my great encouragement to you is, oh my goodness, you can. You can help in profound ways. You can do amazing and wonderful things. Do not underestimate your impact. So the first aspect is assessment. And we, you know, assessment in psychology is slightly different from what all of you may do, but it always begins with noticing and acknowledging and realizing what's going on. So look at beliefs, values, fears, concerns, needs. Ask questions about how the caregiver is feeling physically, emotionally, socially. Studies have consistently shown that most caregivers are wholly of grief. They, like many of the authors of these models, believe that grief starts at the end of a person's life. So when they say to you, I've been feeling angry, I've been having aches and pains, and I feel down, I've been having difficulty sleeping, and you say, that's completely normal for someone who's grieving like you are. And they go, what? You know, what are you talking about? This is incredibly valuable information because just having a name for things goes a long way. If you've ever watched somebody who's had kind of what they call idiopathic, you know, medical complaints for years and years, and finally the diagnostic test comes back and they find out what they have, and you worry so much about telling them their diagnosis, and then lo and behold, they are so thankful, and oh, it all makes sense now, and finally we have a way to move forward. So it's nice for you to be able to know as you're asking them these questions and introduce gently the concept of grief, and that comes into that education component, so that you can provide very gentle education to caregivers about the symptoms and experience of grief, and also remind them that grief is a process and that it's a continuous process, and it's okay to feel like, you know, their mood swing and they feel like things are changing, because that's actually completely normal and very healthy. Grief is a normal experience of all living, breathing human beings. We move into the concept of normalizing. Never, ever, ever underestimate the power of making someone feel normal, right? And just saying, oh, I think everyone would feel angry. You know, it's so common for people to feel anger, guilt, and frustration when they're taking care of a loved one. That is probably one of the most common things I hear. And when I say that to caregivers, when I say to them, I say, you know, the number one thing I think I hear is this frustration and guilt and how they go back and forth. And they look at me and go, really? You know, like it's a shocking concept, but it's so comforting to know actually what you're going through. Most people in your situation go through. And the physical feelings of fatigues, the aches, the difficulty sleeping, that's also normal too. It doesn't mean to say that we appreciate and want these things around, right? I'm not saying that we shouldn't actually advocate for changing things and making people feel better, right? And we're definitely going to talk about that. But it's important to actually know the power of just saying, actually, you're not really that abnormal. You know, most people who are going through what you're going through feel this way, right? And that comes into that validating, right? Never underestimate the impact of just bearing witness. There's an author, Carlos Ruiz Zafón, who said, I would have preferred someone else to have been in charge of rescuing the story, but once again, life has taught me that my role is to be a witness, not the leading actor, right? And so in some cases, you're not going to assume that kind of directive, like I'm going to fix everything role. But the act of sitting there with someone and seeing and bearing witness to their efforts and their pain and what they are doing, it's what we do every day in psychology. And truly, it's what most of you do every day in your jobs. You may not necessarily realize it as validation. But that is powerful in and of itself. And one of the things that we always say is, of course, you know, we are a society that likes to fill space with words. And oh my goodness, don't get me wrong, like pot calling the kettle black. There's nobody who knows how to fill space with words like a psychologist. So do not think that I do not recognize the impact my own field has on this. But our first stage of training is really that act of not speaking. And that act of bearing witness comes from not using some of the traditional platitudes, right? The, you know, everything gets better with time. And, oh, you know, to say, I am so sorry is okay, right? And to offer services and support and, you know, I want to help, right? That's fine. But sometimes we do want to fill that pain and suffering with a reason and a why. And, you know, I have heard things like, you know, God just wanted another angel and, you know, oh, he's in a better place now. And you know what? It's okay for the person grieving to say whatever they feel they want to say, but it can be very difficult to hear things like that, even though wholly well-intentioned. So the best validation really comes from that gentle bearing witness and that support of being present with people. And then alleviating. So alleviating comes in many different ways, but what we can do is help to alleviate grief. And at this point, if you have assessed, if you have educated, you have normalized and validated, let me tell you something right then and there. Any one of you on a day, if someone recognized something you were going through, said, oh my goodness, I recognize this, this is what it's called, it's completely normal, and you're doing the best that you can, any one of you would walk away feeling better. But alleviation comes in many different forms, and we're going to talk about some of those. And the first one, you know, obviously what's really near and dear to my heart is the aspect of actually speaking out loud and processing what we're going through, right? So there's an old AA saying, and I love it. It's everything is smaller when it's out. When we sit and kind of ruminate on concepts and fester on topics, they tend to get big and monstrous and huge. And then we say them out loud like, oh, I feel really guilty, and I was just so angry at him yesterday, and I just feel so bad about that. And then people kind of go, oh, well, that makes perfect sense. It shrinks, right? It's not as severe, and, you know, it's like, oh, wait, you mean I'm not a terrible monster like I thought I was? So in alleviating, encourage process. Most problems come from getting stuck upside down on that grief roller coaster, right? And it's okay for people to toil and fumble and move forward in whatever way they want to, but movement is what we want to emphasize, right? Alleviation of grief comes from just moving forward with that natural process, whatever it looks like for the person. And aiding with coordination of services. Now, you guys, of all people that I've ever worked with, are brilliant at aiding with coordination of services. So I'm going to give you a couple extra tools of the trade that I have kind of found to be helpful. Remember, though, that with caregiving and grief always come the additional stressors that aren't necessarily related to it, but hey, any bit helps, right? So you guys know already medical and financial resources. So if people, in addition to their stress and their grief, are experiencing other things, of course, coordination of services in those realms is very important, right? So you absolutely can help make someone's life easier by giving them some, information on Medicare, or, helping them recognize that they need to actually take somebody to the doctor, kind of the basic foundational skills that you have already. And then there are the additional caregiver resources. So caregiver and support and education, and if any of you have ever worked with it, caregiver support and education can be wonderful. I've done quite a bit of it. But I do want to emphasize that it focuses really heavily on behavioral changes that make caregiving easier. And I think sometimes these poor, burnt out, caregivers who have just worked so hard and are kind of coming in at the end of the rope, come in and get a list of 10 things that they need to do in the home when they get home to quote-unquote make their lives easier. Right? So I really do want to emphasize the fact that it's important to validate first, right? To say what you're going through is normal, and oh my goodness, you're doing your best, and oh, what's it like, and please feel free to talk to me. What would you like to talk about, right? That is perfectly okay. And then tell you what, I know you're doing everything that you can. I know that you are taking such good care and you are trying so hard. And we've actually found that maybe there are a couple things you could do differently, or even get to do less of, that might help you, that might give you a little bit of extra time or a little bit of extra resources. Let's talk about some of those. And that's where you can really transition into that caregiver support and education, because I think sometimes we give people, like in the hospital, we have a whole caregiver support network within the VA, which I've included here, that caregiver.va.gov. And a lot of times it's kind of front-loading people with resources on what to do and really misses out on that. By the way, good job on what you've done already, and we know you're hurting, right? So I really do like to emphasize that your role as kind of a liaison and a consulting person who can help people connect with resources is giving them that little bit of preparation, right? We're not saying you've done anything wrong. In fact, we've just found that some things actually may make your life a little easier, and you deserve to have a little bit of easier. So caregiveraction.org, what I do like about them is they have a peer support network that people can connect to. And then caregiver.va.gov, if you have caregivers who are taking care of veterans, or if you have veterans who are caregivers, you please feel free to send them through to us. I know that there's been kind of a lot of political drama and some comments in the news lately, and absolutely, there are issues with all hospital systems, but there are genuinely loving and caring providers at every VA who want to help out our veterans and their families. And then the National Family Caregiver Support Program, this is actually a directive that provides additional resources, and then Medicare actually has some great toolkits and some really quick info on what we will and will not cover and additional resources. So you can encourage, in fact, you can sit with your clients and go to these websites together and help them understand and look at resources. It can be very helpful. In addition to kind of tangible formal resources, there are grief support groups at most local hospitals, universities, and many different churches. These, in addition to kind of those tangible caregiver resources, provide for that peer support and mutual validation experience, and sometimes fill in those really, really meaningful lost social roles. A lot of the people in support groups, in grief support groups at local hospitals, especially caregivers, understand that you can't get together for coffee every week, but can call each other and really kind of support each other in their awareness of the limitations of their roles. So that peer support is really valuable. And it can be arranged through many organizations, and it can also be kind of a casual thing if you meet someone in a group or a fellow caregiver in a doctor's office, right? People can actually join together. And then remember what we said about that, old AA saying, everything is smaller when it's out. Fostering that process and that communication with counselors, pastors, friends, family, teaching people that what you're going through is normal and it's okay to talk about it, and you're doing a wonderful job, and saying that you're feeling angry, there's nothing wrong with that, because of course that's a natural part of what you're going through, and it's okay to talk about it, and talking about it helps, right? So I do want to make a quick note about the care receiver, because loss of independence is one of the 4 most significant fears of older adults, and care receivers grieve as well. So the stages of grief are also prevalent in the care receivers, especially with the loss of function and feeling like they're placing a burden on their caregivers. So oftentimes you'll see sadness, anger, denial in places like this too. And I want you to think of it as part of the grief process because they're grieving too. And oftentimes I think we can think people are kind of being, cantankerous or they're being resistant. We use the term resistant a lot in treatment settings, right? But the reality is that there's a grief process there too, right? And when you frame it from understanding of grief, then that fosters that compassion and that approach of the issue as more of a grief-related process. And I do want to take a moment and make a note about all of you, because you are healers in the lives of the people with whom you work. And there is nobody that can listen to a story of loneliness and despair without taking the risk of experiencing similar pains. This is a quote from Henry Nouwen's The Wounded Healer. In short, who can take away suffering without entering it? And there's a concept we use in psychology called vicarious trauma, and that there are days when you will be significantly moved by the people with whom you work, even if it doesn't, even if it's not going to impact your life when you go home. It doesn't change the fact that you sit and live and experience their grief and sadness and process with them. So you've probably heard this term 1,000 times. We overuse it in my field too. But self-care is just, in this case, I encourage you to acknowledge that your place is a place of healing, and it is okay for you to feel grief as well, and that entering into the stories and lives of the people with whom you serve is a form of suffering in and of itself, and you may experience any of these stages together, and that is okay. Because only people who are capable of loving strongly can also suffer great sorrow. But the same necessity of loving serves to counter grief and heal, right? So I've included some of the references that I included in this webinar today right here for you. And then I would like to open it up to questions if anyone has any for me.
Thanks, Carolyn. We do have a few questions coming in. The first is, how do you help the individual who seems to be consumed and stuck in a depression or despair mode, especially after more than 2 years of losing an individual?
Absolutely. What a great question. And it's interesting because this has been actually the forefront of arguments in psychiatry, right? Because originally bereavement was excluded from the definition of depression, and then in the DSM-5 they said, cut that out because lo and behold, people who are grieving can actually approach an area of kind of a major depressive disorder. And even though we don't want to pathologize grief, grief can very much lead to that deep depression. So it is true. We have seen people who have not gotten over losses for years and years and years. So in this case, what we want to do is, obviously if there are any concerns about suicide, self-harm, anything like that, we want to refer to a professional. The deep, dark depressions that usually come from grief are the inability to kind of move forward, that resistance to kind of letting go of the person and actually engaging in new stages of life. They can result from feelings like guilt. They can result from regrets. They can result from just kind of a lack of wanting to acknowledge, we call it survivor guilt in our veteran populations. If everyone else died and I lived, what gives me the right to be here, right? So there are a lot of factors that come into play with this, what we call complex bereavement, where people get stuck, especially in that deep, dark depression. And it feels sometimes like a vortex, like a black hole, like you're doing everything in your power to help this person and provide them positive encouragement, and it's almost like you're being drained dry in working with them. So I do want to acknowledge that. My great encouragement is to reinstate hope is the greatest gift that people in everyday life can give people who are in these persistent depressions. The idea that, look, it won't always be like this. It doesn't have to be this way. You can get help. But I do strongly encourage in these cases that they are referred to a professional. We've found that with depression, the most effective treatments are both a combination of some mild form of antidepressant as well as therapy. And I I am a big believer that antidepressant medication should be a temporary kind of aid, right? Some people need it all their lives, and that's okay too, but I strongly encourage you to continue to gently push them toward getting professional help, but whatever you can do to reinstate hope and reason and meaning and that little bit of push for them to move forward, the reinstating hope is what anyone and everyone can do in the life of a person who is in a really dark place.
When is the proper time to reach out to someone who is grieving without approaching too soon?
You know, I think that is a great question, and it's probably the most common experience. And I think some of the old mourning traditions in some of these religions made it a little easier because you automatically did, there was the person was wearing all black and you knew, that you could approach them with your condolences. I think it's never not okay to contact someone who's grieving and offer your support. You may find that they are not quite where you expect them to be because remember that shock and denial is a significant component of grief. And it's also okay for you to call up someone and say, oh my goodness, I heard what's going on for you right now, can I come over, right? There's kind of an interesting discussion and theory on whether or not you should be saying, is there anything I can do? Most people will automatically decline any additional support even if they desperately need it. So what we like to do is actually use kind of that parenting strategy of giving people options and letting them choose one. Would you like me to come over? Can I help by cooking anything for you? People may still say no, but sometimes giving them the options and having them choose between one kind of helps them with that guilt. But it's never too soon. Go ahead and reach out to anybody. The only other sensitivity I would say is, depending on how you heard about it, right? If you want to make sure that that person has an opportunity to tell you themselves, that can be a sensitive issue. But if someone has experienced a loss and it's perfectly okay for you to call them up and say, oh my goodness, I heard, how are you doing? What's going on with you right now? And let them kind of allude to what stage they're really in right now, whether or not they're in shock, and just sit with them in that, right? And actually tell them, hey, shock makes sense. Shock is a part of grief.
Thank you, Carolyn. We do have a lot of questions still coming in, but I want to be respectful of everyone's time. So feel free to send in questions. We'll get those answered by Carolyn separately and send that document out to everyone and answer all of the questions that we didn't get a chance to get to today. Just a few quick announcements. We do have the November and December webinars available on our website. If you want to register for the Stay Cool This Yule with Hazel Heckers on November 20th or our Tax Planning for Aging Adults, that's going to be taking place December 1st with Deanna Whitlock. Also, everyone, one major announcement, we have the call for proposals for our 2015 CSA conference. If you are interested in being a speaker or you know anyone that's interested, please feel free to go to our website and check that out. We'd love to have your submissions in to be a speaker. So thank you again, Carolyn. It was lovely having you, and we will see you next time.
Thank you.